Good afternoon. Welcome to today's Grand Rounds presentation. Reminder that there will not be a Grand Rounds next Wednesday. Also a reminder to please fill out the attendance records and also to fill out the program evaluations, and please give us any ideas that you might have in regards to future topics and future speakers. Our speaker today is Dr. Lou Scallon. Dr. Scallon attended medical school at the University of Iowa and then did his ophthalmology training at the Medical College of Wisconsin, where he was a chief resident. He is currently on the staff here at Mary Grilly and also at Wolfe Eye Clinic, and he's here today to discuss ocular emergencies. And please join me in welcoming Dr. Scallon.
Thanks, Dr. Hallberg. It's a pleasure to be here. I was asked to speak about ocular emergencies today, and as you can imagine, I could show you some pretty graphic things, and I'm going to do that, but I decided to save them till the end of the talk after you finished your lunch, so eat quickly here. So in addressing ocular emergencies, it's really important to keep your eye on the ball. Some people are better at that than others. Some of the conditions that I'm going to talk about today are things that require urgent attention, and whether you deal with them in a quick, timely fashion can have a major impact on how the patient's outcome is. One thing that we're faced with occasionally are chemical burns, and the outcome of these injuries really depends on how quickly a patient is treated, and it's important that they be treated in the field if possible, as quickly as possible. There are several different types of chemical burns. The most severe are alkali burns, which are caused by basic solutions such as lye, drain cleaner, cement, even the powder from airbags. But probably one of the most common ones that we're faced with here in Iowa are anhydrous ammonia burns. Farmers put this source of nitrogen on their fields twice a year, in the fall and the spring. And during that time, they can be exposed to this chemical that can cause disastrous burns of the cornea in a very short order. Acids also can cause damage. They're a little less severe. People that jump their car batteries, if they don't hook them up properly, the battery can explode. And a lot of times the acid will fly up into their face. Chemical reagents that are used in industry and at Iowa State and some of the labs around the area also can be damaging. But again, they're not as severe as the alkali burns. Things like detergents, irritants such as mace and gasoline also can cause irritation, but they're usually not as severe. So we grade these as being mild to moderate. And in mild to moderate burns, the cornea may be a little scuffed up. It can have focal areas of fluorescein uptake. Sometimes they'll have corneal abrasions. The conjunctiva is typically swollen and red. One key thing to think about is that they may have some foreign bodies, especially if they've had something like a car battery explode in their face that you need to be watching for and taking care of. And the periocular skin can be irritated. And here you can see a patient, conjunctiva's injected, the cornea is a little bit scuffed up, and the skin is erythematous. In more severe chemical injuries, the cornea can be edematous or swollen. They may have large epithelial defects. Their conjunctiva is more swollen and injected. But even more ominously, if the conjunctiva is pale, that's a sign that it's necrotic. And the underlying sclera can also be ischemic, and so that's an ominous sign. Again, if a patient has gotten drain cleaner, particularly the particulate type that's in their eye, you need to make sure that they don't have foreign bodies that are lodged under the eyelid, because it gives prolonged exposure. They may have elevated intraocular pressure and second to third degree burns of their skin and significant intraocular inflammation such as iritis. And this is a patient with a severe alkali burn, and you can see the cornea is quite edematous and opacified. Down below, you see that the conjunctiva is a beefy red here, but more ominous are these white patches where the conjunctiva is ischemic, and you're seeing the sclera underneath it. So this patient has a very poor prognosis. But the quicker that they're treated, the better the prognosis is. So again, just to reiterate, treatment should be started immediately at the site of the injury with whatever fluid is available. If you've got a patient with a ruptured globe, though, you've got to be careful not to put pressure on their eye. And so unless they have a severe alkali injury, I wouldn't do a lot of irrigation to a person with a ruptured globe. Your goal is to get all of the chemical exposure out of the eye, and you can use normal saline or lactated Ringer solution if you're in a clinic or in the ER. If you're out in your neighborhood or whatever, you should use tap water or whatever you have available, and irrigate for at least 30 minutes. If you're in the ER, you want to check the pH at the end of the irrigation to make sure that the eye is neutralized. And you have to stop the irrigation for 5 minutes before you check the pH, so that you're actually checking the pH of the tear film rather than just checking the pH of the irrigating solution. Of course, if you're in the emergency room or in the clinic and you have some topical anesthetic that you can put in the eye, it's going to be much, much more comfortable for the patient. And you may have to repeat the anesthetic every 10 to 15 minutes to keep their eye comfortable. If you have a lid holder or a Morgan lens in the ER, it makes it much easier. And again, you want to irrigate under the eyelids and even swab under the eyelids with a Q-tip to make sure that there's no particulate matter that's been retained. In mild to moderate burns, you can treat them with topical antibiotic drops such as a fluoroquinolone 4 times a day if there's not a significant epithelial defect of the cornea. If there is a significant epithelial defect of the cornea, I like to use erythromycin ointment because it coats the cornea, it's a little bit more comfortable for the patient, and helps the healing a little bit. Of course, these patients will have some significant discomfort afterwards, and so it's important to provide them with pain control. Moderate to severe burns should be referred to an ophthalmologist immediately after the irrigation is performed, but you don't wait to call us until you've started the irrigation process. To prove the point of the importance of immediate treatment, Acada did a study in 2006 that showed that 76% of patients who were irrigated on site with tap water had mild injuries, whereas 86% of people with significant corneal burns who are not irrigated had more serious injuries. And the mean healing time for those who were irrigated on site was 8 days, as opposed to 29 days for those that were not. So seconds count in dealing with these injuries. Staying on the cornea, often we're called to the emergency room here at Mary Greeley to evaluate people with corneal ulcers. And these are infections of the corneal surface. And when you look at these patients, you'll see a focal white opacification of their cornea. And they may or may not have some staining of the overlying epithelium with fluorescein. They often have injection of their conjunctiva, and they can have a mucopurulent discharge on their eye. As you all know, the eye, particularly the cornea, is extremely sensitive, so they have a lot of pain, light sensitivity, and if the corneal ulcer is in the center of the cornea, they typically have decreased vision. The most common agent that causes corneal ulcers are bacteria. In warmer climates, fungal ulcers are a bit more common. Acanthamoeba is an amoeba that's found in contaminated water, can cause severe infections, and of course it's important to think about the possibility of herpes simplex or herpes zoster virus causing an ulcer. Typically these patients have the classic dendritic pattern of staining on their eye though. A huge risk factor for the development of corneal ulcers is contact lens wear, particularly wearing the contact lenses overnight. Wearing contact lenses while you're sleeping increases your risk of serious infections 10 to 15-fold. And it may just take one time. We often present with a college student that slept with their contact lenses in once and they wake up the next morning and their eye is painful and blurry. Just an aside note, if you have a patient that is getting recurrent conjunctivitis in your clinic and they're a contact lens wearer, sometimes the multi-purpose disinfecting solutions that people use to disinfect their contact lenses, such as Renew or Optifree, can start to burn the surface of their cornea and cause irritation. And there's some other ways to disinfect the contacts. So if you've got a patient that's getting recurrent inflammation and wearing contact lenses, it may be the contact lens that's the cause. Swimming with contact lenses, especially in contaminated water, is a huge risk factor for this development of acanthamoeba keratitis. And of course, prior corneal abrasions or ocular trauma can cause corneal ulcers. And this is why we typically treat patients that have corneal abrasions with an antibiotic to help prevent it. Corneal ulcers always cause a permanent scarring of the cornea. And so if the ulceration is in the center of the cornea, they're going to have a permanent visual impairment. So the quicker you can get them treated and the more effectively you get them treated, the better their outcome is going to be. Small, non-staining peripheral corneal ulcers without significant discharge, you might start the treatment yourself if you're evaluating them in the clinic or the emergency room, and then refer them to their eye care provider using a fluoroquinolone drop every 2 hours while awake. If they're a contact lens wearer, they need to be treated with both a fluoroquinolone and tobramycin, because contact lens wearers are at somewhat increased risk for developing Pseudomonas corneal ulcers, which can be particularly virulent and progress very rapidly. Central or larger peripheral staining ulcers should be referred to an ophthalmologist right away. So this is a small peripheral corneal ulcer. It's not going to affect the patient's vision unless it isn't treated and gets out of control, which at this stage probably would not. So they can be treated with just drops as an outpatient. This is a severe ulcer. This is a type of ulcer that you might see in a Pseudomonas infection, and you can see that the cornea is opacified. The conjunctiva is very red. They have some mucopurulent discharge, but especially ominous in this patient is that they have what we call a hypopion, which is a layering of white blood cells or pus in their anterior chamber. So this is going to leave this patient with a permanent scar and impaired vision that could only be corrected with a corneal transplant. But the quicker that you can get them referred to us and we can culture them and start treating them with fortified antibiotics, the better they're going to do. Another thing that we're often called to the emergency room to address is acute angle closure glaucoma. And by definition, this is caused when the trabecular meshwork is occluded by the peripheral iris. The trabecular meshwork circles the area around the peripheral cornea, and this is where the fluid, the aqueous fluid, drains out of the eye. The risk factors are people that are farsighted. People that are farsighted, their eyes are shorter than they should be, and there's not as much room between the iris and the cornea. As people get older and their cataracts start to get thicker, the cataract can start to push on the peripheral iris and push it toward the cornea, starting to close off that anterior chamber angle. Family history is seen, and pupillary dilation, either with drops in the clinic or systemic anticholinergic agents such as antihistamines or antipsychotics all say that if you have glaucoma, you should not use this medication unless it's cleared by your eye doctor. This is what they're referring to when they give that warning, is that people with narrow angles, if they take systemic anticholinergics, it can dilate their pupil somewhat and push the peripheral iris into the anterior chamber angle. If you have a patient that has narrow angles and they need to take this medication, we can treat them by doing a laser treatment in the office to make it safe for them to take it. So this does not come up very often, but that's why that warning is given. Sometimes we're asked whether a patient that has had cataract surgery might be having an attack of angle closure glaucoma if they present with pain. But patients that have had cataract surgery, their anterior chamber angles are wide open, because once you take the cataract out, it leaves a large space for the fluid to drain between the iris and the cornea. They might have glaucoma for other reasons, but they're not going to have acute angle closure glaucoma. So these patients can present with pain, headache, nausea, or halos, any combination of those things. And it seems that they usually come in about 2 o'clock in the morning. The signs that we see are elevated intraocular pressure. If you look with a pen light or a slit lamp, you can see that there's not very much space between the inner aspect of the cornea and the peripheral iris. They may have corneal edema that causes the halos around lights that they might see, conjunctival injection, and a fixed mid-dilated pupil. So the treatment for these patients is to call us so that we can do the definitive treatment, which is a peripheral laser iridotomy, where we create a pinpoint opening in the peripheral iris to create a new channel for the fluid to safely drain through the eye. And so for the vast majority of these patients, this is curative. And so this is a photo of a patient that's having an attack of angle closure glaucoma. You can see the injection of the conjunctiva. The cornea is hazy. The pupil is fixed and mid-dilated. And if it were a 3D photo, you would see that the iris was pushed up in the peripheral part, touching the peripheral cornea. Moving on to neurologic emergencies of the eye, papilledema. Patients that have headache that present to your clinic or to the emergency room, if you look at their fundus, you may see that they have swelling of their optic nerve heads. And that's the definition of papilledema, is swelling of the optic nerve caused by increased intracranial pressure. One key thing to differentiate this from other causes of swelling of the optic nerve is that patients with papilledema do not have a significant decrease in their vision. They might have just very transient, momentary spells where their vision dims just a little bit, but that's caused by shifts in their body position and a change in their cerebrospinal fluid pressure. They may have headache, double vision, which is caused by a sixth cranial nerve palsy, which also can occur with increased intracranial pressure, and again, nausea. And so as opposed to patients with optic neuritis or ischemic optic neuropathy, they do not have a decrease in their vision. Usually the optic nerves are swollen in both eyes, although it may be asymmetric in the early phases of papilledema. Their optic nerves are reddened or hyperemic. The nerve fiber layer going into the optic nerve is edematous and appears white, and this blurs the disc margin and blurs the retinal vessels. The retinal veins may look dilated or tortuous, and you don't see the venous pulsations that are present in about 75% of the population. So this is a photo of a patient with papilledema, and you see that the optic nerve is erythematous. You see this white elevation and swelling of the nerve fiber layer, the little nerve fibers that are going from the retina into the optic nerve, and you can see that the retinal vessels are dilated. Rarely, you can have patients that have a condition called optic nerve drusen, which is a congenital defect of the optic nerve, where they have this abnormal calcification, little crystals of the optic nerve that blur the disc margin. But you don't see the obscuration of the retinal vessels here. They're nice and sharp, and you don't see the whitening of the nerve fiber layer going into the optic nerve. This is another differential thing in considering swelling of the optic nerve. This is a patient with a central retinal vein occlusion. And the hemorrhages here typically extend far beyond the area right around the optic nerve. Typically, these patients have a decrease in their vision as well. Usually this is unilateral and is usually acute. So I'm going to talk about optic neuritis in just a minute. Another thing to consider in a patient that has bilaterally swollen optic nerve heads is that they may be having a hypertensive crisis, where if their blood pressure is over 200, sometimes people's optic nerves become swollen bilaterally. So it's important to check the blood pressure on patients that have optic nerve swelling. Ischemic optic neuropathy is an infarction or decreased blood flow to the optic nerve that can also cause swelling. I'm going to talk about that in a minute. Other things that can cause swelling is compression of the optic nerve by a tumor in the orbit, or Graves' disease that's particularly severe, or anything that's causing infiltration of the optic nerve, such as sarcoidosis or metastasis. And so to run through in your mind the potential things that could be causing papilledema, it's anything that can raise the intracranial pressure. Probably the big one first to rule out are intracranial tumors. Hydrocephalus may be seen in children particularly. Benign intracranial hypertension or pseudotumor cerebri is a diagnosis of exclusion after you've excluded everything else. Any type of intracranial bleeding or arteriovenous malformations or venous sinus thrombosis can also cause bilateral optic nerve swelling. So again, it's good to do a complete workup, checking the blood pressure, physical exam. These patients all need emergency MRI scans with gadolinium contrast. And if there's no sign of intracranial bleeding or tumor, they should have emergent lumbar puncture with CSF analysis, and making sure that you check their opening pressure when you do the lumbar puncture. This helps you identify whether they do indeed have benign intracranial hypertension. Optic neuritis, in contrast, is caused by an inflammation of the optic nerve rather than raised intracranial pressure. Typically, patients with optic neuritis present with a history of a several-day progressive loss of vision. And usually it's unilateral. They sometimes will tell you that they have pain when they move their eye around. And this is because their optic nerve is inflamed, and when they move their eye, their optic nerve actually hurts. They may notice that they have decreased color vision perception, and light intensity appears less in the affected eye. So if you take your pen light and shine the light in the unaffected eye, it's going to appear much brighter than the light intensity in the eye that's affected. This is one way that you can check for optic neuritis. Oftentimes, they may have associated focal neurologic symptoms such as numbness, weakness, or tingling. They may have had a prior flu-like prodrome. One key thing is that only one-third of patients with optic neuritis have swelling of their optic nerve head. 2/3 of the patients with optic neuritis have no swelling. Their optic nerve looks pretty normal. And that's because the part of the nerve that's inflamed is back behind the eye, and so you don't see any swelling. Typically, they will have some visual field defects that they may notice that their vision is blanked out or blurred in areas. And we can plot that out if we do formal visual field tests. So this is a patient that has optic neuritis. Their optic nerve looks relatively normal, but after the process has died down a little bit, you may see some permanent pallor or atrophy of the optic nerve, and you can see that pallor atrophy on the temporal aspect of the optic nerve here. The most common type of optic neuritis is idiopathic. And second is multiple sclerosis or other demyelinating disease. In fact, optic neuritis, I believe, is the most common presentation of demyelinating disease. Childhood infections or immunizations and other viral infections have been reported to cause optic neuritis. Anything that inflames the meninges, causes an inflammatory process in the orbit or sinuses. Severe sinusitis can cause optic neuritis. And similarly, granulomatous disease that's affecting the optic nerve can cause some inflammation as well. So again, you want to check their blood pressure, visual field. These patients need an MRI scan also with gadolinium contrast. And if you see evidence of demyelinating disease, they should be referred to neurology for further evaluation and treatment. Sometimes you can actually see swelling of the optic nerve on the MRI scan in patients of optic neuritis, and it helps confirm your diagnosis. You could consider getting a CBC, checking for syphilis and some other inflammatory conditions, particularly if the clinical course is a little bit unusual. So another cause of disc swelling is ischemic optic neuropathy, and there are two types. One is arteritic, or caused by inflammation of the blood vessels leading to the eye, and the other is non-arteritic, which is caused by decreased perfusion for any other reason. Atherosclerosis, diabetes, hypertension, hyperlipidemia, elevated homocysteine, anemia, sleep apnea. We've just found that this is a definite link over the past few years with ischemia of the optic nerve. I had a patient last year that had a perforated bowel and had a long protracted surgery. He was hypotensive. The surgery was not done here, and he woke up and he was blind in both eyes because he had poor perfusion of his optic nerves during the prolonged hypotension. So hypotension is also a potential cause of ischemic optic neuropathy. Another thing that may be linked with it is use of phosphodiesterase inhibitors, such as Viagra, Levitra, and Cialis, and all those commercials that give you the warnings talk about dimming of the vision, and it's because there may be some link. I've had 3 people in my practice that have used these agents one time and have presented with ischemic optic neuropathy. So there have been some studies that have done about it, and there's not a conclusive causal link, but they certainly are concerned enough that they give the warning for patients that if they feel their vision is dimming, that they stop the use of these agents. In ischemic optic neuropathy, usually the vision loss is unilateral. But if you have a patient with severe temporal arteritis or giant cell arteritis, they can lose the vision in both eyes very quickly, so it can become emergent. Patients with giant cell arteritis may have headache, jaw claudication, scalp tenderness, proximal muscle and joint weakness that you would see in patients with polymyalgia rheumatica, which is associated with this. They may have anorexia, weight loss, and fever. The vision loss in patients with non-arteritic ischemic optic neuropathy is usually painless. And this is a photo of a patient with ischemic optic neuropathy. Again, hard to distinguish this from the other causes of disc swelling, but sometimes you do see some segmental pallor of the optic nerve where the ischemia is particularly severe. So, in approaching these patients, you want to really key into whether they may be having giant cell arteritis. Check their sedimentation rate, C-reactive protein on an emergent basis. If the sedimentation rate and C-reactive protein are high, you start them urgently on either IV methylprednisolone or high-dose oral prednisone. And kind of base this on how severe it is, how high their sed rate is, and whether they have any significant visual loss in terms of how aggressive you are. But you always want to err on being more rather than less aggressive, because people can permanently lose their eyesight on a very rapid basis. If you think that they may have arteritic anterior ischemic optic neuropathy, and you want to get a temporal artery biopsy within a week of starting them on starting them on corticosteroids. You don't wait for the biopsy, you start the treatment first. But you don't want to wait too long to get the biopsy, because you may have a false negative if they've been treated with the steroids too long. If a patient has no symptoms of giant cell arteritis, a normal sedimentation rate, and a C-reactive protein, then it's important to move on to doing some other testing, checking their blood pressure, making sure they're not diabetic, making sure their blood pressure is under control, that their lipids are reasonable, that they don't have anything that would be making them hypercoagulable, and also to make sure that they don't have sleep apnea. The things that I've talked about to this point are sight-threatening, but this one is life-threatening. This is an isolated third cranial nerve palsy, where you see an abnormality in the motility of the eye. Their eye doesn't move around properly. And even more ominous is when their pupil is dilated in the face of an isolated third cranial nerve palsy. So this is a patient with a classic right third cranial nerve palsy, and you can see ptosis or drooping of the eyelid here. It's droopy compared to the left side. The pupil is dilated and the eye is turned down and out. So this is a classic isolated third cranial nerve palsy. And I had a lady that presented with this a couple months ago in my office, and we had to rush her over here to get a stat evaluation. The big concern with these people is that they may have an aneurysm in their brain that's ready to explode. And so you need to get right on it and make sure that you're getting them evaluated. Just because they have this doesn't mean that they have an aneurysm. Sometimes they will have some ischemia of their optic nerve, or of their ocular motor nerve, particularly if they're older. But if their pupil is dilated, you have to urgently rule this out. Other causes are trauma, tumor, maybe congenital. If they have acute swelling of their pituitary gland or pituitary apoplexy, it can cause an isolated third cranial nerve palsy. Children in particular can present with ophthalmoplegic migraine, where they'll have a transient disturbance in their ocular motor nerve, and they can present exactly like this patient, but you would not want to make that diagnosis except as a diagnosis of exclusion after you've gotten an MRI, MRA. So You don't spend a lot of time getting an extensive history. You do want to make sure that they don't have giant cell arteritis, maybe question a little bit about that. Make sure that the other cranial nerves are intact, because that may lead you down a different path if they have multiple cranial nerves involved. But they need to have an urgent MRI, or magnetic resonance angiogram, for all pupil involving third cranial nerve palsies and all pupil sparing third cranial nerve palsies for patients under age 50. So people that are 50 and under, even if their pupil is not dilated, they still need this urgent. People who are 50 and older, where their pupil is not dilated, it just may be a transient ischemic thing that usually resolves on its own, so they don't necessarily need to have the neuroimaging on an urgent basis. So moving on to another emergency that we're often asked to consult about in the emergency room is retinal detachment, which people do much better if they're caught early and treated early. And there are some things, if you're triaging a patient or evaluating them, that might help you distinguish whether they're having retinal symptoms versus migraine. The flashes that precede retinal detachment typically are very brief and isolated. Patients describe them as lightning flashes or sparks going off inside their eye. And you contrast that with the scintillating lights that are seen in migraine, where it's kind of a shimmering thing, but that's constant. It's not an intermittent just spark or flash. Another key thing, if you have a patient with any kind of visual disturbance that you're trying to evaluate, it's always good to have them cover one eye and then the other. Because a lot of times if people have a visual field defect, they think it's just in the eye where the visual field defect is. In other words, if they have a visual field defect on the right side, they may say it's their right eye. But really, if you cover each eye, they can see it out of both eyes simultaneously. That means they've got a process going on in their brain. So that's a quick, easy thing that you can do. And so a patient with ophthalmic migraine, usually they're seeing these scintillating lights in both eyes simultaneously. So if you have them cover one eye, then the other, and they can see it out of both eyes at the same time, it means that it's happening in their visual cortex of their brain, not in their eye. Oftentimes, retinal detachment is preceded by a burst of floating spots or strands inside the eye. And if it's not caught in time and their retina is starting to actually detach, they see the classic curtain or shadow coming across their vision. But you want to get them checked before they get to that point. Most retinal detachments are caused by an acute separation of the vitreous gel from the retina. And this is a common thing that happens to the majority of people over the course of their lifetime. All of a sudden, the vitreous gel loosens and pulls away from the retina, and in a small percentage, it can tear the retina and cause retinal detachment. Other possible links with retinal detachment are prior trauma, high myopia. Patients that are myopic, their eyes are longer than they should be, and the retina is thin and tears more easily. Patients that have a family history of retinal detachment are much more likely to have retinal detachment themselves, and any prior ocular surgery is also a risk factor. So if patients are examined properly and we catch it when the retina is torn before the retina detaches, we can treat it much more easily. We can do laser retinopexy or treat around the tear in the office to kind of spot weld around the tear to keep the whole retina from pulling off. And this is a patient that has a retinal tear right here. You can see this kind of white opacification where the retina is torn. There's a little bleeding where the retina got torn, a little blood in the vitreous. And so this was caught early, and this series of laser spots was applied around the tear to seal it off. This is a patient where it was not caught in time. And here the retina has detached, and you can see this bullous elevation of the retina. It appears kind of white and crinkled. The retinal vessels are somewhat obscured, and so this is going to require surgery to fix. And lastly, ocular trauma, of course, is an emergency, and unfortunately fairly common. There are 40,000 eye injuries a year that result in permanent visual impairment. And the National Society to Prevent Blindness considers that 90% of these injuries are preventable. One of the most common things that presents to the emergency room is hyphema. which is bleeding into the anterior chamber from a ruptured iris blood vessel. And this can happen just with blunt trauma. I saw a high school student yesterday from Story City that was in a food fight and got hit in the eye with a grape yesterday and had some bleeding into his eye. So it can be fairly innocuous. So one of the key things that you want to do for these people is to put a shield over their eye so it doesn't get bumped or rubbed anymore. And so I told him he could go to school today if he wore this shield. Couldn't go to basketball practice. And he asked me, well, why do I have to wear the shield? And I said, keep grapes out of your eye. So anyway, the other things that you want to do are to have them avoid taking aspirin or any of the blood thinners. You want to have them not do straining type activities, lifting or bending, because as the blood is dissolving or if further pressure is put on the eye, they can bleed more. And if they bleed a second time, often it's worse than the first time and can cause some problems with severe glaucoma. These patients that have had blunt injury like this can develop some late problems with glaucoma or retinal detachment. So it's good that they be evaluated by ophthalmology. If you have a patient like this that's got a lot of swelling of the conjunctiva, it's important to think that in the face of trauma that they might have an actual rupture of their eye underneath this swelling. So you want to take the precautions of covering their eye with a shield too. That's the primary thing that you can do, whether you're in the clinic, whether you're out in the field, whether you're at home and you have a family member that has an eye injury. And you may not have a shield, but you might have a styrofoam cuff that you can cut the base off of and put it over their eye and put some tape over. You don't want to put anything directly on the eye to put any pressure on the eye. But it really is important to keep any further pressure from being placed on the eye because it can cause some real problems. You would not miss this by any means. Obviously this eye is very distorted. The retina, the iris is distorted. They've got this bleeding. And again, if you put pressure of any kind on this eye, the contents of the eye can come out. The retina can be exposed. So that's a key thing that you want to prevent. If there's been any concern that they might have a retained foreign body, you would get a CT scan of the brain and the orbits with axial and coronal views. You definitely do not want to get an MRI scan in patients that you think might have a ocular foreign body because the magnetic field of the MRI scan can cause further damage. So just a CT only. You can start treatment with IV cefazolin and a fluoroquinolone. And another key thing that should be done as soon as possible is to give them antiemetics so that if they're nauseated, they don't vomit. Because if they start vomiting, they can have the intraocular contents extrude as well. And of course, you always want to make sure that their tetanus status is up to date. So I don't know whether any of you ever watched that old TV show ER, but they had one episode that they had a patient with a traumatic retrobulbar hemorrhage, and it was the only TV show where I've seen the ophthalmologist be the hero of the show. So this is a condition where patients, if they've had trauma, get significant bleeding behind the eye, and it can also happen with eye surgery. If they have a blood vessel that opens up and starts to bleed behind the eye. What the big concern here is if the bleeding causes so much pressure and the eyelids constrict the eye from coming forward, there can be pressure from both sides on the eye, and the pressure in the eye can go up so high that the blood flow is stopped in the eye. And so you can have an infarction of the entire eye, and they can have permanent loss of vision if you don't address this very quickly. The patients present here with proptosis, conjunctival swelling, and lid hemorrhage. So if their vision is dim and their pressure is high in the eye, the thing you need to do is what's called a lateral canthotomy, and it's relatively easy to do. And I think some of the ER docs are trained in their training to do this, where you inject xylocaine over into the lateral cantho region of the skin, take a scissors, split the skin vertically, and then detach the lateral aspect of the eyelid from the orbital rim so that the eye can move forward and it relieves the pressure. The chance to be a hero, I guess. So this is the Grand Canyon. My wife and I were fortunate enough to be able to hike in and out of it 3 weeks ago, and beautiful scenery like this reminds you that eyesight is valuable and worth trying to protect. So that's all I have. Any questions?
Periorbital swellings and redness around the eye from cellulitis or trauma or whatever. How do we know which ones we need to act right away and which ones we can?
There are two different classifications. One is called preseptal cellulitis, which is an infection just of the skin on the surface of the eye. It hasn't gotten back into the orbit itself. And that's like any other type of cellulitis, where the skin is tender, swollen, and it can spread to get back behind the eye and cause a more serious orbital cellulitis. So you want to treat the preseptal cellulitis pretty aggressively. But if a patient has decreased vision, impaired motility of the eye, where their eye is not moving around like it should, they should be treated emergently for orbital cellulitis. And that's life-threatening too, because if you get an infection of the orbit, it can travel back through the cavernous sinus and get into the brain. And so you treat them with admission to the hospital and intensive IV antibiotics. And it's also important to get a CT or an MRI scan of their orbit. Sometimes they'll have sinusitis that's so severe that it's spread from the sinus into the orbit. And so you have to address both things. Sometimes they'll need drainage of their sinus to get the infection under control. Good question.
Lou, thank you very much. That was a really nice presentation. I think probably one of the things that the audience picked up on was the people that you had, the 3 people that you had that had tried Viagra, Cialis, and Levitra and had loss of vision. Did they have the disc at risk, and what do you counsel these patients?
That's a good point. They did have, all of them did have the disc at risk, and what Dr. Lehman is pointing out is that people that have non-arteritic anterior ischemic optic neuropathy often have an optic nerve that's small and doesn't have very much hollowing out or cupping. And we can tell that by looking at their optic nerve, whether they have an optic nerve that might be at risk for developing ischemic optic neuropathy. So there is a certain subset of the population, just because of the morphology of their optic nerve, are at somewhat increased risk. So there's some thought that if patients are wanting to take the phosphodiesterase inhibitors like Cialis and so forth, that they could have their eyes checked to see whether their optic nerve might be at risk. Do you have anything else that you would add to that?
How common is that?
Not very common. Yeah, that's the thing. I mean, obviously there are lots and lots of people taking it, and it doesn't happen very often.
I tell people there's a lot of people that are risk for ischemia, and that these are very, very common things, and that, so just like one of my favorite books was when I read about a flu vaccine, and there's a picture of Ford getting it, and the Surgeon General says, tomorrow there'll be 68,000 strokes and 42,000 heart attacks and all this, and then of course all the reporters are saying, well, what are you giving this vaccine for? And the Surgeon General says, because that's what happens every day. So I tell people, that you have the risk, if you have risk factors, if you have hypertension, if you have diabetes, you have risk factors for ischemia. So you have to decide. But I really counsel them differently, whether they have what their optic nerve looks like.
Lou, I want you to start over. I didn't see all your slides.
Leo, you can, they have it on YouTube, Leo.
Oh, all right. When you guys do an eyeball exam, and I'll be vernacular, do you measure cup to disc ratio? Is that part of, so if I could say they saw Lou Scallon, I'm talking about the Viagra issue.
Yes.
I mean, you record it's 0.3 or whatever. That's part of a normal recorded automatic on an Epic,
Yes.
whatever.
So,
Optometrists do that too? Like I'm getting fitted for cataracts. Is that, somebody looks in my eye and that's part of the routine?
yep, if they're doing what they're supposed to do, they should be doing that. So
Okay.
if they have any significant cupping, like 0.2, 0.3, they're probably not at risk for it. But if they don't have much of a cup at all or just very little, that's potentially a higher risk patient.
Right. Well, we get, urology get questioned on that, and Linda's comments are right. It's rare, but
They have
when they come to me, I always say, well, to be sure, I could have you see an ophthalmologist to get an eye check, and then it's the best we can do, which is still a rare problem. But, okay.
Well, I hope I didn't spoil your lunches. Thank you all.